moderator, Dr. Siddharth Latif, to conduct the session.
Good morning, everyone. I welcome you all to this session on orbital diseases and tumors under Pakistan Orbital Oculoplastics Association. I welcome all of you here on this session. And without wasting further time, so as we can maintain the discipline of the day, I will request our first speaker to please join us on the podium, Murtaza Samin. Okay. I think the speaker has not reached yet.
He was there. He was just here 2 minutes before the next.
Okay. Meanwhile, we will request Professor Dr. Asad Aslam Khan to please join us on podium. And topic of his presentation is management of choroidal melanoma.
Bismillahirrahmanirrahim. My talk is about management of malignant melanoma, very rare disease, orbital disease in this part of the world. So our orbital work, mine, Professor Tayyir Saab, obviously Dr. Zahid Kamal, we all owe this to Professor Munir Al-Aqsab, late Professor Munir Al-Aqsab, who taught us about orbital diseases, how to approach the patient with an orbital disease. So he was our mentor, and our everything we do good to the patient is because of him. So my talk is about management of choroidal melanoma. We all know that malignant uveal melanoma is a malignant tumor arising from the melanocyte in uveal tract, and most common primary intraocular tumor in adults with an age-adjusted incidence of 5.1 per million. And there is strong tendency for metastasis, particularly to liver, and the choroid is the most common site involved. There are certain risk factors, largely considered to be a sporadic, but there are risk factors: light iris color, light skin color, ability to tan, Northern European ancestry, rarely a family history of uveal melanoma, and pre-existing choroidal nevi. Pathophysiology: the uveal melanoma develops from the unregulated colonial proliferation of uveal melanocytes, and there are mutations related to 5 genes in this regard. For diagnosis, there are certain symptoms. 30% of the patients are usually asymptomatic, and 38% they complain of disease, decreased vision. 9% they report with photopsia. 7% floaters, and 6% have peripheral visual loss. Only 2% of the patient complains of eye pain. Clinical diagnosis is basically on fundus examination, and for us, we depend on the size of the tumor on ultrasonography. And clinical diagnosis on fundoscopy, there is a collar button mushroom configuration of melanoma. There are 3 sizes of melanoma on which we depend about the prognosis: the small, medium, and large. Our whole management depends on the size of the choroidal melanoma. Diagnostic imaging, we do go for fundus photography. There is serial fundus photos are critical in the follow-up of choroidal nevi and melanoma to judge or to decide whether the lesion is increasing in size or there is chance of malignancy or not. Fundus are autofluorescence. Ultrasound is our main parameter on which we depend, and on which we depend what type of management we are going to go for this particular patient, whether we are going to observe, whether we are going to go to local resection, whether we are going to go for enucleation or any other. This is primarily the diagnostic test that confirm the diagnosis of melanoma, and ultrasound also is useful in determining the size, thickness, apical height and base dimension, extraocular extension, and document growth during the follow-up of a suspicious nevus or small melanoma. OCT does have a role, but standard OCT doesn't penetrate deeply enough for detecting the internal characteristics of choroidal neoplasm. Now, management. There are different management regime mentioned in literature, in books. So, in summary, they recommend us either go for observation, go for surgery, radiation, laser, medical management, or combination of any of the above uh, management plans. Observation is mainly basically for to judge or to look for metastatic risk, and that has been observed with increasing millimeter tumor thickness. So this is that is why we go for every month ultrasonography, the size of the tumor, fundus photography, and judge whether the patient the growth of the lesion is increasing in size, in thickness or not. Surgery, there are three surgical plans: enucleation, exentration, or local resection. Enucleation is mainly indicated for advanced melanoma that occupy most of the intraocular structures and have caused severe secondary glaucoma or total retinal detachment that is not reversible to alternative treatment, or tumors is invading the optic nerve. Exenteration is mainly if it the tumor has come out of the eyeball invading the orbit, then it is recommended that go for lid sparing exenteration. And third method is the local resection. If after repeated uh, series of B scan, we see that the tumor is not increasing in size, and however some way it is causing some problem, like it may be causing cataract formation or glaucoma, but it's not increasing in size. Then we it is located in front of anterior to the equator. Then we can go for local resection and can be performed using a partial lamellar sclerouvectomy technique, best performed in growing small size ciliary body melanomas or choroidal melanomas near the equator. Radiation management, it is recommended in literature either go for plaque brachytherapy or external beam radiotherapy. For three of our patients, we consulted different oncologists in Lahore, and and every one of them in the institution at Mayo Hospital, at other hospitals, but they say we don't go for plaque brachytherapy or external beam radiotherapy. So we had no option for these patients except to go for enucleation. Laser therapies are also recommended, and they are photocoagulation, transpupillary thermotherapy, and photodynamics. In our study, which we conducted at Mayo Hospital from 1996 to 2022, it's still going on 27 years. Total number of orbital lesions we came across were about 2,651, and we analyzed only 2,068 because the 583 either left against the medical advice, or when they were referred to other departments, they never came back. And out of these 2,068 cases, 482 were ocular tumors. And out of these ocular tumors, 30 were malignant melanoma. They were constitute 6.2%, 2% of the ocular lesion. And they presented either mainly, most of 96% of the patients, they presented with when there was the extra ocular extension of the tumor. This patient had painful blind eye, secondary glaucoma. So management, because of presentation at advanced stages, almost all of the patients had to undergo enucleation. In one patient, where there was no increase in size of the tumor and it was located anterior to the equator, and all tests to rule out systemic spread, transscleral excision was done. So this is just a very Laker. This patient ultimately developed cataract, but tumor was not increasing in size. It was located anterior to the equator. So we just did transscleral excision of the tumor. Just pause forward.
Discussion ready at the end of the after the session, after the presentation.
So we expose the sclera, Then
If you
inferior
want to
rectus
दरम्यान में
muscle
कर
was
देते हैं।
disinserted. फॉरवर्ड करनी है कोई करना ना यार आ नहीं रहा फॉरवर्ड वाला so after disinserting the inferior rectus we mark the sclera according to the size of the tumor shown in the ultrasonography and location. Then we made incision in the sclera. Raised flap to expose the melanoma. Flap were raised, the tumor itself bulged out. We didn't have to make any incision in the tumor. It itself came out. We just, with blunt dissection, removed the whole tumor. Even we didn't do the vitrectomy. Just open sky vitrectomy was done, no intraocular with the cutter. And then restitching, and after the restitching we applied cryo over the sclera. Then, so this is, but unfortunately, when we sent the tumor for histopathology, it turned out to be malignant melanoma again. So, our oncologist advised enucleation in this case as well, because I discussed with the oncologist that tumor, there was no, I didn't feel that there was any extension to the neighboring area, so it itself came out the whole of the tumor, but they advised that no, you have to go for enucleation. So this patient went for enucleation as well. So the summary of our management till date, for all patients we came across, that for the small to medium-sized tumor, we observed for millimeter increase in size of the tumor, and we look for plaque or external beam therapy or laser therapy, which is not available at least in Lahore. So for large size tumor, which is filling the whole of the eyeball, causing glaucoma, extraocular tension, enucleation for eyelid sparing exentration is recommended. Thank you very much.
Thank you so much, sir. Anyone has any comment or question to add? Yeah.
Assalamu alaikum. Thank you very much, Professor Hassan. That was a good series of 30 cases. Let me have some experience at Al Shifa Trust Eye Hospital regarding the choroidal melanoma. There are a few observations which are not very much consistent with the international observations. The first is that we have relatively younger population of choroidal melanomas. Most of our cases which have come across are less than 40 years, while Elsewhere in the West, it is above 60 years, 70 years. So that is the first difference. Second difference is not uncommon. Over the last 4 or 5 years, we have seen more than 20 cases of every month, every week almost, sometimes every fortnight, we see one case of choroidal melanoma. So it is certainly not uncommon. And the third thing is that elsewhere outside, even in India, the cure rate of choroidal melanoma with brachytherapy is over 95%. And brachytherapy is a dream therapy. And hopefully, inshallah, we will get soon in Pakistan. And just brief you, some of our those who are aspiring to become oculoplastics, that there are three mostly types of brachytherapy which are being used. Number one is most commonly used as ruthenium, which is used in India as well, and hopefully in Pakistan. And that ruthenium is up to 6 millimeter of thickness. And second is iodine, which is in America, and that is goes up to 12 millimeter of thickness. And third is strontium, which is lesser, but 3 millimeter, up to 3 to 4 millimeter. But it has got an advantage that you only need to give it for 10 minutes. For ruthenium, you have to give 4 days. Plaque has to be there. But the problem with ruthenium, the advantage of ruthenium is that it has got a 1 year half-life, which means for 1 year you can reuse it for patients. One plaque will be enough for 1 year. But for iodine, it's only for 30 days. So, unfortunately, as Professor Asad has said, so far enucleation remains the only option. But I will suggest, at the risk of rebuttal, that we observe, and enucleation probably is the last option, because that is another observation, although it's not documented, it is not proved so far, but it's our observation that metastases are not that early, and we can wait, we can see, and let's hope that some better treatment regime is available. But the metastasis doesn't come earlier, so do not go for enucleation right away. Assess it, serially observe it, and then we can. Thank you very much.
Now I request Mr. Murtaza Samin to please join on podium. The topic of his presentation is a rare unilateral primary orbital malignancy in a 7-month-old child.
Bismillahirrahmanirrahim. Good morning to all once again. And this purpose of presenting this presentation, it is a very rare tumor which reported. Usually it occurs in adults after the age of 20 years. So this is first time happened in not first time, but it is very rare. So a 7-month-old child from Afghanistan was presented to Al Shifa Trust Eye Hospital, Rawalpindi, with complaints of sudden progressive unilateral proptosis of the left eye, and it was non-axial proptosis, which was increasing in size very abruptly. So parents brought that this proptosis is increasing very progressively, and it is also bleeding, and ulcerative lesion is also there. So they come to us at the age of 7 months after the presentation of 4 months. So neuroimaging was done. I don't want to go into detail of other. Neuroimaging was done on MRI. The sagittal section and axial sections I have mentioned, they show the intraorbital mass, which was around 9 centimeter in length and 5 centimeter in width, and it was approximately 280 grams, right, in weight. So we decided to carry on the surgery as soon as we got the GA fitness, because as the tumor was continuously bleeding, the hemoglobin of the child was 7 hemoglobin. So we asked for blood transfusion, and when the hemoglobin came up to the 9, then the anesthetist gave us green option to go for the surgery. and even the veins were not, palpable. So it took a very long time. A dedicated team of anesthetists helped us, and they did general anesthesia, and then we were able to perform. This is me, and I am thankful to Professor Tayyab Saab for giving me this opportunity and trusting me. So I and with my team, we did this surgery, and we decided to enucleate the eye because the mass was increasing very rapidly. The child was uncomfortable, crying, and bleeding was there. So this is the post-operative picture, and this is the mass in the kidney tray, you can see, which we enucleated. Here you can see this. Okay. Sorry, exentration. Exentration was done. So we sent this for histopathologically. Histopathologically, we sent to Armed Forces Institute of Pathology for the immunohistochemistry, and it turned out to be undifferentiated small round cell carcinoma. So this is very rare tumor. Okay. So it in Pakistan it is reported that only 62 cases have been reported. So post-operatively, systemic antibiotics, analgesics, and ointment were advised to the patient, and daily dressing with povidone iodine. And one thing I must advise to the whole, that when we are doing evisceration, enucleation, or exentration, you have to remove crepe bandage after at least 4 to 5 days, because I have seen those who remove immediately the second day crepe bandage. After 24 hours, patient come back with us with the orbital hematoma. Then we have to again drain it or treat it aggressively. So this is the literature review. It also supports that Ewing's sarcoma is a bone tumor that seldom affects the orbit. Most youngsters with a small male predominance are affected in their second decade. So this is a rare case. That's why I am presenting here. That this type of tumors usually occur in second decade, but it has been reported in a 7-month child in its neonatal age. Another study says that neonatal malignant primary orbital tumors are extremely rare. Different previous report, early symptoms in 3 Chinese neonatal tumors included mild proptosis, but tumors grew rapidly. Early surgical resection is recommended to save lives and preserve visual function. So I conclude this case report by saying that any unilateral childhood aggressively progressive tumor should be considered very aggressively and treated very aggressively, and it should be considered for a malignancy. So this is all about which I want to share with you. Thank you. Sorry, I was saying enucleation, but it was exentration. My mistake. Thank you. Sir, I have given this to a journal in CPSP journal, and it will be published soon, inshallah. Sir, they have accepted.
That's good news. That's it.
Okay, sir. Thank you.
Sir.
My collection of 15 or 16 cases of rhabdomyosarcoma, 2 were infants, 2 and 1 was congenitally one, and that came out to be rhabdomyosarcoma. This blue cell tumor is the same family, I think.
Yes, sir.
So could it be a undifferentiated rhabdomyosarcoma?
Sir,
Because it has been reported and it's confirmed. And
30
I have got 2 cases.
Sir, right. You are, sir, right. 35% of the childhood tumors are rhabdomyosarcoma, and this is also one of the family of rhabdomyosarcoma. But we can differentiate or we can treat because oncologist wants the specific, the tumor markers. So they apply immunohistochemistry, and they have said that this is the undifferentiated type of the rhabdo. So they have gone on deeper layers. They are doing this, sir.
Thank you.
So you are, sir, right. I agree that in childhood rhabdomyosarcoma is 35% tumor.
Thank you very much.
Thank you, sir.
So we'll hold the question and answer session at the end of the session. Otherwise, we will we'll not be able to finish with all the speakers.
Next, I will invite Mr. Shahid Tarar. His topic of discussion is lateral orbitotomy.
Thank you very much, sir. Starting with the lateral orbitotomy, this is the procedure I think every oculoplastic and orbital surgeon has to do. And this is the procedure where you are stuck for anything, you can go for lateral orbitotomy and approach the orbit. So first of all, whenever being surgeon, you should know the anatomy, basic bones. We have all know, but just for residents, if you are not aware of, familiar or forgot, you must go through the relevant anatomy, intraorbital structures, the eyeball, the muscles, the nerves, and this is the lateral rectus. Once you remove the lateral orbital wall, and if the specially tumor is within the intraconal space, then you need to disinsert the lateral rectus, and later on at the end of surgery, you reinsert. So veins, venous drainage, arterial supply, zygomatic bone. So indications: laterally placed extraconal tumors, then intraconal tumors, lacrimal gland tumors, if it cannot be removed through anterior orbitotomy, then the lateral orbitotomy is the option. So again, to go for the incision is stellate right incision or the lateral crease extension. So any of the incision can be given for lateral orbitotomy. You can see, you incise the skin, then muscle, and then go to the periosteum, and then incise the periosteum, then separate the periosteum with the then you can further extend it. You can cut the periosteum, or with the periosteum elevator, then further you separate the periosteum from the bone. Just you can see, and once you have removed this is the bone is exposed, and which you can cut it. Again, the orbital retractors, so that the other structures are not damaged once you are removing the bone. Remove part of the bone, and you should be knowing that the anterior margin is thick and the posterior is thin layer. Once the anterior part, thick layer is cut, it is very easy to remove it with the bone punch. So then next is you dissect it from the space within the orbit, and with the help of cryo you can remove the lesion, and then the layers are again repaired back. The periosteum, usually the 50 vicryl is the suture I am using. So post-operative care like normal, specifically keep in mind whenever you are operating orbit, you must examine your patient in the evening after a few hours for the pupil or for the vision, just to look for the signs of retroorbital hemorrhage, because that will be an emergency to intervene. So this is one of the case which we operated. 65 years lady presented with left proptosis, and just to show you the scan, you can see this is all is the tumor. Okay, if you can see the eyeball is, you can see here starting from at this place, all this posterior part up to the apex, this is all the tumor. And here you can appreciate The inferior rectus, medial, and probably here is the superior. Lateral rectus is difficult to appreciate. Again, here you can see this is the tumor and this is the eyeball because it is pushed anteriorly. Again, look at the tumor size. Okay, the eyeball is pushed anteriorly. The tumor is more than the size of the eyeball. So this is the incision, the local anesthetic with adrenaline, just given to reduce the bleeding. This is the post-op removal of the bone and then the tumor. Properly. So this is the video just to show you with the, you can see you have to be again very gentle and very soft once you are removing with the cryoprobe. If you are holding the tumor with your tooth forceps, that will bleed and that will be difficult. So that is the reason the orbital surgeons, they need this cryoprobe. So again the bones are lateral orbital wall placed back. So this is the size of the tumor, about 3 into 2 centimeter. So this is the pre-op and you can see the eyeball is pushed back. So with this you can appreciate the pupil. So the vision was, Alhamdulillah, was fine. I think it was not anything credit on my part, but I'll tell you whom credit goes. So you can see the extraocular movement were fine. The lateral rectus, whatever the tissue was felt, I tried to reinsert it. And at the end of, later on, you can see the eyeball can move laterally. So credit goes to this man, my teacher. Thank you very much.
Thank you very much, Dr. And now I request Dr. Sida Latif for her talk about lacrimal gland adenocarcinoma, primary exenteration versus adjuvant therapy.
Assalamu alaikum and good morning, everyone. Today, the topic of my discussion will be the lacrimal gland adenocarcinoma and its management, whether it should be treated with primary exenteration or adjuvant therapy. Acknowledgement for this goes to Professor Dr. Asad Aslam Khan because he is the primary treating physician as well as the surgeon for all of these cases. So, lacrimal gland adenocarcinoma is very important because not only is it associated with a quite high mortality, it is also associated with much morbidity. And not only the morbidity is related to the pathology, it is also related to the treatment of this pathology. So that's why we need to see which treatment methodology we need to opt in these patients. And we all know it arises from the glandular epithelial cells of the ducts. And first of all, the patient presents to us with proptosis and we perform a biopsy of that mass, and the biopsy proven adenocarcinomas are then diverted toward the orbital oncologist or towards the oncologists. And literature review. In 2018, American Journal of Ophthalmology, they published this research that globe preserving surgery has a favorable long-term survival outcome, and not only the globe survival, there was also vision survival for a median of about 3 years. Then again in 2018, there was a study published in Plastic Reconstructive Surgery that eye sparing surgery with adjuvant therapy had a better loco-regional as well as systemic metastatic control. And in 2020, another study in radiation oncology, they claimed that in T1, T2 disease, eye sparing surgery had satisfactory results. However, they said that T3 and above, radiotherapy was not enough with eye sparing surgery. They needed to add chemotherapy. Yet again, we move forward in 2021, British Journal of Ophthalmology. A study claimed that there was better disease specific survival when eye sparing surgery was done and radiotherapy was opted instead of exentration. Santosh Honavar in 2022 published that eye sparing surgery and adjuvant radiotherapy had a better local as well as systemic metastatic control. Then a curious review which included of about 440 cases, they claimed a 5-year OS overall survival of 65%, and the detriment in the OS was noted at T4 stage and with positive tumor margins. They also highlighted that as most of the patients are living beyond 10 years, so it was also important to reduce the morbidity. Keeping this literature review in mind, eye sparing surgery and adjuvant therapy seems to be a very good option. However, we need to see in our local population what are the after effects of opting one treatment over the other. For that purpose, we decided to conduct this study ourselves. And we designed a study in which we compared patients who underwent primary exentration with those patients who had adjuvant therapy after their biopsy surgery. So it was a quasi-experimental study, and the consecutive patients who presented to Mayo Hospital, Lahore, we included in the study for about 5 years from January 2017 to December 2021. It's quite a rare malignancy, so the time interval that we needed to observe the patient was for a longer time, so that we had a sufficient enough strata to prove our results. Our inclusion criteria was all those patients who were proven as lacrimal gland adenocarcinoma on the biopsy. We did not keep any age limitation because of the paucity of the patient population already. Exclusion criteria, however, was if there was any pre-existing systemic disease or if there was bone invasion. So we kept our inclusion criteria to T4A stage of the disease. The operational definitions, exentration, we all know, removal of everything from the orbit. Adjuvant therapy was decided by the oncologists at Mayo Hospital, and they decided to give 2 grays daily fraction for about 5 weeks, so a total of about 50 to 70 grays. And biopsy proven lacrimal gland adenocarcinoma included was T4A as per the AJCC TNM classification. And patients of proptosis underwent excisional biopsy. They were included in the study. Informed consent was taken. Patients were offered primary exentration. And then upon their decision, they were divided into group A and B. Group A, those who opted for primary exentration, and the B patients who did not opt for it, and they underwent adjuvant therapy. Group A had exentration, which was done in the ophthalmology department, but group B, radiotherapy, was done in the oncology department. 6 months into the treatment, we asked the patients to fill the FACT-G questionnaire, which is the Functional Assessment of Cancer Treatment General Scoring System. And at 1 year, we noted the side effect profile, and we followed each patient for 2 years to calculate the overall survival. And we tried to stratify the disease into T1, T2 strata and T3, T4A strata. However, the proper stratification was not possible because of the small size of one of the stratas. However, we did apply chi-square to calculate if the results were significant. So mean age of our patients was 50.5 years, a maximum of 70 years of age and minimum of 18 years age patient was included in our study. 3 patients opted for primary exentration. Out of them, T3, T4A disease, 2 patients were of T3, T4A disease, and in the adjuvant therapy group, more patients with T1, T2 disease, they did not want to sacrifice their they did not want to sacrifice their eye or their vision. That's why they opted for the adjuvant therapy. Out of our total of our 11 patients, 8 were alive at the endpoint of 2 years, so our overall survival was 72.7%. It is to be noted that this overall survival was more than what has been calculated in the literature. That's because mostly the overall survival is calculated at about 5 years, and our survival is being calculated at 2 years. So mostly by 2 years mark, the patients are still alive. If we can take the study forward, probably the data will change. And in the group A patients who underwent primary exentration, 100 patients were alive at the 2 years mark. In group B, the adjuvant therapy patients, 5 patients were alive at the end of the surgery. So overall survival for this group was 62.5%. This graph is showing you the comparison of the overall survival of exentration and adjuvant therapy patients, 100% versus 62.5%. Now, when we stratified the disease in the adjuvant therapy patients, the five patients who had T1, T2 disease, the survival was 80%, whereas the patients who had T3, T4A disease, the overall survival fell to 33.3%. This was the point which we then theorized that dividing the disease into T1, T2 versus T3, T4A is important if you want to opt for adjuvant therapy in patients. Lower is the strata of the disease, higher the chances that the patient can opt for adjuvant therapy. However, if the disease is advanced, it is better if you go for the primary exenteration. Another thing that we had in the study was the FACT-G score, as I said. So we calculated higher scores were seen in exenteration group in physical well-being and in the financial well-being. In the social well-being and emotional well-being, the scores were better in adjuvant therapy. However, the statistically significant difference was only found in the physical well-being versus social well-being scores. Overall, the total score of FACT-G score in exenteration was 43, in adjuvant therapy 41. This is not a statistically significant difference, which shows that the treatment functionally, physically, emotionally, or socially is equitable for the patients, and the patients do not feel that there is any difference between the two. The complications reported at 1 year follow-up. In primary exenteration, we only saw difficulty in wound healing or infection in the patients, which was quite amenably sorted. Adjuvant therapy group patients, because they underwent radiotherapy, they had skin changes, dry eye, keratitis, cataract, and a patient who had to undergo chemotherapy after the radiotherapy. By the oncology department, they reported deranged LFTs and chronic liver disease. And sadly, this was a very young patient, a 40 years old female. So, to conclude, what we suggest from this study and from these results is that although it seems very intriguing that we go for eye-sparing surgery and we do the adjuvant therapy, however, most of the patients, if the disease is slightly advanced, T3, T4A, it's better if we guide them towards primary exenteration because it is associated with better overall survival. It is associated with better FACT-G scores as well, and the patient will be disease-free, morbidity-free. And with the adjuvant therapy, the morbidity that the patient faces is especially the systemic morbidity like chronic liver diseases and derangement of LFTs, that goes beyond what is expected in the primary exenteration group. So we need to tailor our treatment as per our patients, and we need to report our results. Thank you.
Thank you, Dr. Sidra. Now the next speaker is Dr. Sadia Imtiaz. Her talk is about intralesional bleomycin for orbital and periorbital vascular malformations.
This one. What's your name? Yeah.
Assalamu alaikum. I'm Dr. Sadia Imtiaz, Senior Registrar at Institute of Ophthalmology, Mayo Hospital, Lahore. Today, my topic of discussion is intraluminal bleomycin for the treatment of orbital and periorbital vascular malformation. Before I start, I would like to declare no conflict or financial interest. As per International Society for the Study of vascular anomalies are actually classified into two: vascular tumors and vascular malformations. Vascular tumors where there is proliferation of the endothelial cells, while without any risk of proliferation of endothelial cells, these are regarded as vascular malformations. Vascular malformations further classified as slow flow vascular malformations and high flow vascular malformations. Slow flow vascular malformations being the capillary hemangiomas, lymphangiomas, and varices, while the arteriovenous malformations are regarded as high flow vascular malformations. So coming towards the rationale of my study, as we all know that the vascular malformations are actually very difficult to remove via surgery due to the risk of many per-op complications, as well as there remain high level of recurrence. So the sclerotherapy and the embolization are considered as the first line treatment option. For the embolization, we know we need the presence of interventional radiologists, and we rely for this on interventional radiologists. So the bleomycin, which is a cytotoxic anti-tumor antibiotic which is derived from the streptomyces, has gained popularity as the sclerosing agent. This makes the objective of my study, which is to determine the safety and the efficacy of intralesional bleomycin in the treatment of orbital and periorbital vascular malformations. For this, a quasi-experimental study was conducted at Institute of Ophthalmology, Mayo Hospital, Lahore, for a period of 12 months, and it comprised of 15 patients. Patients of either gender between 10 to 40 years of age with orbital and periorbital vascular malformation having the radiological confirmation were included in this study. Elderly patients, patients who were previously treated via surgery or with intralesional steroid injection, and patients in which tumor was only resided in the intraconal space were excluded from this study, as well as the patients of lung disease, because bleomycin can cause the pulmonary fibrosis. For this, a specially designed performer was used, and after doing the detailed ophthalmic examination, ocular assessment was done, especially the visual function testing, and the lesion-specific examination was done. Pre-op investigation comprised of ocular investigations in the form of orbital B scan, CT or MRI, along with angiography, and the systemic evaluation was also done. So this was the CT scan of a patient with capillary hemangioma, and this was a CT angiogram of a patient with AV malformation. After taking the informed consent, we actually carried out this study where the emergency care settings are available. 15 international unit bleomycin injection was used, and it was diluted with 1.5 cc of normal saline. So this 1 cc of bleomycin now contained 10 international units, and it was diluted with 2% of lignocaine in a dilution of 4:1. So the bleomycin dosage actually was 0.5 mg per kg of the body weight, but maximum dose should not exceed 10 international units per session, and 3 to 4 sessions can be given 6 weeks apart. Before injection, 2 ml of intralesional fluid was aspirated prior to injection, and the maximum injected volume should also not exceed more than 4 ml. Post-injection treatment in the form of the systemic antibiotics along with anti-inflammatory and the topical anti-inflammatory applications were given, and the 4-hourly visual functioning test was done. Follow-up was done at 1 week, 1 month, and 3 months interval. Coming towards the result, mean age recorded was 23 years with a predominance of male 67%. Coming towards its types of cases, we had 33% cases each for the varices and the lymphangioma, while 20% cases were of capillary hemangioma and 13.3% cases were of AV malformation. Mean number of injections given per patient was only 1.5 at 1 monthly interval. Safety outcome was actually assessed in the form of any per-op or post-op complication. Only 4 patients out of 15 actually had the complication. Among those, 2 patients had eyelid swelling, 1 patient had sore throat, which was a case of lymphangioma, and 1 patient of varices developed the hematoma formation that resolved within a week. Efficacy outcome was assessed in the form of the size reduction, and the mean pre-op size was 2.5 into 3 centimeter that reduced to 0.5 into 0.6 centimeter at 1 month interval with a significant p-value of 0.012. This was a first case of orbital varices, and this is the post-op after 1 month. This is another case of orbital lymphangioma where the intralesional bleomycin was injected to this female, and this one at 1 month follow-up, and the further injection was not given to this lady because she was pregnant at that time. She got pregnant afterwards. This is the third case of AV malformation, and this is after 2 month follow-up. So, in conclusion, intralenal bleomycin is by far less traumatic, inexpensive, and comparatively easy technique of administration. Therefore, this study recommends intralenal bleomycin as a first-line treatment for periorbital vascular malformation in terms of its safety and efficacy. These are the references which are related to this study. Any questions are welcome. Thank you so much.
Thank you, Dr. Sadia. Next, I request Dr. Abdul Basit to come to the podium. His topic is Spectrum of Orbital Diseases Presenting to a Tertiary Care Hospital. Spectrum of Orbital Diseases.
Assalamu alaikum, ladies and gentlemen. I have a pleasure of presenting this topic to all my teachers, my seniors, my mentors, Professor Dr. Tayyab, Professor Dr. Sophia Iqbal, Professor Dr. Ibrar Hussain, Dr. Shahid Tarar, and Dr. Zaid Kamal. I'm extremely grateful and honored to be presenting this. So far you have been going through different presenters and topics, explaining different diseases and different conditions in detail regarding the treatment and the prognosis. And we will, in the end, I'd just like to take all of you through a bird's eye view of all the orbital conditions that we are usually encounter in our daily practice at tertiary care hospitals. So this, first of all, this will be like an overview. This is a comprehensive analysis of different orbital diseases presenting. So we collected about 36 conditions overall. So there'll be analysis, detailed examination, frequency, percentages, gender distributions for these conditions, and also the clinical impact, which is important in accurate recognition, timely diagnosis, and effective management of these orbital diseases. So we actually classified, made a classification of our own, together with my supervisor, in which we classified all these diseases into 8 broader categories, which pretty much encompasses all these conditions. So starting off with infections, it's a common knowledge for all the oculoplastic people that orbital cellulitis was the most common, with 21 cases, and mostly children, followed by orbital mucormycosis, which was the most common condition of orbital infections encountered usually in patients with diabetic and old age patients and with systemic immunosuppression. And we had one rare case of hydrated cyst, which was discovered after biopsy confirmation after orbitotomy. Then coming to the inflammatory conditions, again, like everybody knows, thyroid eye disease being the most common, and there were all kinds of stages that we were getting the disease in, followed by idiopathic orbital inflammatory diseases, which we had a case or two, and also a few cases of Wegener's granulomatosis, sarcoidosis, and IgG4 disease in one case as well. So the trauma cases which presented, so these were all the cases which we encountered, with orbital fractures being the most common, the floor fracture being the most common with 6 cases, intraorbital foreign bodies in 4 cases. There were cases of retrobulbar hemorrhages also. There were cases of other more complex traumas with multiple orbital wall fractures, which needed collaboration with the maxillofacial department for repair. And then we had benign primary orbital tumors, which included all these cases, dermoid cyst being the most common with 13 cases, capillary hemangiomas, we had orbital lymphangiomas, and like the previous presenter said, that treatment is usually done with sclerotherapy with bleomycin, but thankfully none of our patients got pregnant with bleomycin. So this was a rare complication. Then we had some malignant primary orbital tumors as well. RMS being the most common, usually in the younger age group. We had a case of lacrimal gland carcinoma. We had a case of orbital lymphoma as well, which was bilateral in one case and unilateral in another. And also a case of Ewing sarcoma, which was confirmed after histopathological diagnosis, and later on exentration was performed for the patient. So coming to the diseases which encompass the metastasis from the surrounding structures to the orbit. So like usually we see over here, late presentation of most diseases due to poor socioeconomic conditions and lesser patient education. So we get these cases all the time of lid tumors extending into the orbits, of sphenoid wing meningiomas, etc., extending into the orbits, and also like melanomas, basosquamous, and we had a case of even sebaceous gland carcinoma, which had taken over all the orbit, which we had to exenterate, and even I think the patient did not even survive later on. So we had all these cases. So then coming to the next category with orbital tumors, which involving the orbit from distal metastasis, secondary tumors. Mylar sarcoma was the most commonly seen with about 3 cases. And in about 2 of the cases who were children, this was the first time they were diagnosed to have myeloid leukemia. So they presented with a mylar sarcoma to begin with. Then we had a case of renal cell carcinoma and a lung tumor mets, and both of these were in elderly patients with known cancers. So coming to the malformations, so we had also had like other malformations. We had a case of indirect carotid cavernous fistula, and this specific patient had been roaming around for like quite some time before we diagnosed that patient. And then we had orbital varices and a few orbital lymphangiomas as well. So the summary and key findings being, so the total conditions that we encountered, the total disease, there are 36 of them. The top most common infectious condition was the cellulitis, orbital cellulitis. The top inflammatory condition being the thyroid disease, and the top benign tumor being the dermoid cyst. So basically, this study provides valuable insights into the prevalence and general distribution of various orbital diseases in a tertiary care setting. And having in mind and to know what to expect in all these cases will help better diagnose and treatment planning for these patients. I rest my case. Thank you very much.
Thank you so much. Now I request Professor Dr. Zahid Kamal Siddiqui Saab to present his topic, sinonasal orbital diseases.
Bismillah ar-Rahman ar-Rahim. We in the earlier session we discussed the case of maggots, and this is very unfortunate. This patient came to emergency of Mayo Hospital unaccompanied, and he was unconscious, and for 3 days nobody came, and the director of emergency services said he's got no specialties accepting this patient, so please come and take over. So orbital department took it over, and I realize Surah Bani Israel, Rabbi arhamhuma kama rabbayani saghir. तो इसमें रब का लफ्ज़ इस्तेमाल हुआ, रब्बा यानी से, जैसे औलाद को माँ बाप पालते हैं उस तरह हमने उनका ख्याल रखा. So as we discussed earlier about the variety of orbital disorders, we have got good neighborhood. Most of the time we have got ENT department established close to us, and so is the nose and sinuses that are very close to the eyeball. And that is just the revision, and you can see that all the sinuses, they are surrounding the orbit. This is variety as you presented, Abdul Basit, at you. So mostly we start with inflammatory disorder. Professor Andhava is here. He's going to present on thyroid eye disease. We'll skip that part. In fact, mass diseases, fractures, and congenital disorders. But always, before you diagnose, go back to the basics. Record all the findings. Where is the dystopia? How the eye movements are affected? And is it affecting the visual field? Before you embark on any intervention, please record all the damage that has already been done. Because once you operate, everything is on your shoulder. Then the family and the patient will think that it was okay before. So that is the integration. we need to involve all the departments. This is a patient who had, immediately after marriage, she was traveling and she had a roadside accident, unfortunately. The eye was lost, it's a tricycle eye, but very unsighted. So we repaired the orbital fracture and a prosthesis was implanted so that she can have a better cosmesis. Here is the orbital cellulitis, and you can see that sometimes they present with pouring pus. Again, go back to basics and start with the intravenous. Admit these are the situations where you really need an admission, because now most of ophthalmic service has gone into daycare surgery, but immediately admit these patients and go through all these investigation, especially the CT scan. And if you find an abscess, along with the ENT colleague, you can drain the abscess and the recovery is remarkable. You can have happy child after good intervention. And the child are very secretive sometimes. If they have an injury and retained foreign body which was presented several times from KP, they do not tell the parent and they can come up with the orbital cellulitis. The other very common disorder in the sino-orbital setting is invasive fungal granulomas, and do not forget that it can invade the brain as well. So need to involve neurosurgeon. And as we had COVID, we had a big series of COVID-associated mucormycosis. And all the centers in Pakistan were busy dealing with these. You can see that the horrible appearance immediately, pan sinus involvement. Intravenous amphotericin B was the mainstay in these cases, but again, you know that it is very expensive and we had to smuggle it from our neighborhood. But whenever there is a possibility of reducing the disease burden, you can do that along with the ENT colleague. This was a case who was getting the whole cornea was getting exposure because of seventh nerve palsy, and we removed the orbital mucor and did tarsorrhaphy, and his globe was saved. Malignant tumors like squamous cell carcinoma, you can see the herbal remedy she has applied on the face. So these are different factors that delay the approach of that patient, and she came to us with advanced orbital squamous cell carcinoma. And this is a case of basal cell carcinoma which was neglected, and it invaded nose, sinuses, but fortunately the brain was not. So a huge extended exenteration was done, and we had to involve our plastic surgeon colleagues to do the reconstruction with flaps and partial thickness skin from thigh. And nonetheless, sometimes we have got the ocular tumor which are again neglected and they go beyond into the orbit and sinuses. You can see this child with the retinoblastoma. Radiotherapy has been done, chemotherapy has been done, but still the disease has gone inside into this zygomatic bone. So we did an extended exenteration for her. Congenital lesions we were discussing, you can see the huge mass here, probably a dermoid of some kind, and she had good outcome after removal. So questions we are going to do at the end, but the message is that whenever you come across a disease that is involving orbit and sinuses or nose, always invite your friends and take their expertise on the board, So the patient can get best of the treatment, which we are very lucky. We have now available different specialties in our tertiary care. Thank you.
Thank you, sir. Now I request Professor Dr. Asad Aslam Khan to present his topic, Surgical Approach to Orbit, a simplified rendition for residents.
Bismillahirrahmanirrahim. This talk was mainly about residents, but all the residents, they have gone to learn PECO.
All of them have gone for a lunch.
so जी मैं कहा my talk was basically for residents, but all the residents, they have gone to learn PECO. So just a brief overview of the surgical anatomy of the orbit. And we all know that the pear-shaped cavity, a wall at the apex and base are the curvilinear, apex and base are composed of thick bones, walls are thinner and perforated by various foramina. And length of the orbit is 45 millimeter from medial orbital rim to apex, and medial walls are parallel to sagittal plane, and lateral walls are shorter by 10 millimeter, recessed at 45 degrees. The contents of the orbits. So element of the orbit can be organized in group of 7. 7 muscles, 7 bones, 7 nerves. The muscle, inferior rectus, superior rectus, superior oblique, inferior oblique, medial rectus, lateral rectus. And I will not go into detail of the nerves and bones. This was just a review for the residents. So this is the muscular arrangement and facial arrangement of the orbit. The nerves innervating the muscle from inside, and this is the sensory. So these are motor nerves, and on the right side is the sensory nerves. So then how to decide about an approach to an orbital lesion? The principle to keep in mind when deciding an approach to take out an orbital tumor or lesion, they are either to take a total or en bloc excision of the lesion, maintain visual acuity, limit injury to the nearby structures, lowest post-operative morbidity, and cosmetically acceptable. These are surgical spaces: intraconal space, extraconal space, tenon space, subperiosteal space, and extraorbital space, which are perineal sinuses and intracranial cavity. So these are the mainly surgical spaces where we perform our surgeries. And the lesion distribution in the orbit, they are, if we talk about extraocular lesions, they are mainly the cyst, lacrimal gland, cavernous hemangiomas, schwannomas. If we talk about the intraconal lesion, so these are related to the optic nerve, either medial to, either lateral to, superior to, or inferior to optic nerve. And they are mainly the optic nerve tumor itself, neurofibromas, lymphangiomas, hiatus cysts, schwannomas, cavernous hemangiomas, dermoid cysts, cavernous hemangiomas. So these are, and in the subperiosteal space, it is mainly the subperiosteal abscess. So this is the main common distribution of the lesion in the different orbital spaces. The types of orbitotomies we do, they are according to the location of the lesions. So anterior to the equator, we go for anterior orbitotomy. Posterior to the globe and medial to the optic nerve, we go for deep medial anterior orbitotomy. Posterior to the globe and lateral to the optic nerve lesion, we go for lateral orbitotomy. And for the lesion is the posterior 1/3 of the orbit, optic nerve and chiasma. This is transcranial and transnasal orbitotomy. And this last approach is done in collaboration with the neurosurgeon and the ENT surgeons. So several approaches may be identified, but the types used by the ophthalmologists are anterior, either superior along the superior orbital margin, inferior along the inferior orbital margin, or medial, which may be either through the skin or transconjunctival, or lateral orbitotomy, according to the lesions which are usually behind the eyeball and they are intracorneally located. Anterior orbitotomy, this is the anterior orbital approach. The incision is given skin, orbicularis, septum, orbital fat, and then we approach the lesion. I will very briefly show different videos of 1 minute each of each duration. Anterior orbitotomy. So this was a case of osteoma of the frontal sinus, very hard lesion. So incision was given just along the anterior orbital margin, and we identified the superior oblique muscle, and underneath it was a big bony tumor, osteoma of the frontal sinus of the orbit. There are places the saw doesn't work, then we have to use the hammer and the chisel. And this came out to be a very big osteoma. So this was the anterior orbitotomy along the superior orbital margin. Then we come to the lateral orbitotomy. This is mainly done for the intracorneal tumors which are lateral to the optic nerve, inferior to the optic nerve, superior to the optic nerve, or very big tumor of a lacrimal gland tumor which are growing in the backward direction, and for the hydatid cyst or other cysts which are located in the retrobulbar area. Step by step lateral orbitotomy, skin incision, opening temporalis fascia, raising periosteum, securing lacrimal gland, removal of the lateral wall, reflect lateral rectus and dissect bluntly through the soft tissue, remove the lesion, cryoprobe may be applied and clear of the lesion in incision in layers. This is the bone exposed, and after removing the bone, there was a case of very, very big hydatid cyst, and it would have come without lateral orbitotomy. Approach to the medial orbit for the lesions which are located medial to the optic nerve. The medial transconjunctival approach, or even through the skin, we can approach these lesions with medial actus disinsertion. So this is a transconjunctival orbitotomy. It was lesion which was removed through the transconjunctival approach. So this is all about the surgical approach to the orbit. Thank you very much.
Thank you, sir. Now I invite Dr. Fawad Randhawa. His topic of discussion is use of selenium in thyroid eye disease.
Thank you, sir. Thank you, madam, for inviting me. Among us, the ophthalmologists. A very relevant topic, and as Professor Zahid told us, that is a teamwork. The most important aspect is the timing. And this is why selenium is being kept in this topic, because it's still relevant. You can see in the PubMed, when I searched in the National Library of Medicine, selenium studies were they are still ongoing, and there are lots of studies which are being ongoing, and nobody is actually sure whether to do it or not. So that's why in endocrinology, the only thing that matters is pathogenesis. We can't go beyond pathogenesis if we can't treat it with, if we don't know the basics. So सिर्फ एक इसके ऊपर time लगेगा, बाकी सर इंशाल्लाह ताला it will. You can see here from left to right, T cells and B cells are the crux of the matter. These are the baselines which are we have to be kept in mind, because it is an inflammatory condition, as Professor Zaider told you, and because of the activation of these two cells and the fibroblast, which is initially non-active, these are actually stimulated by the inflammatory cytokines, and they respond to two most important mediators, which actually leads to the new advents of medicines for Graves' disease, which unfortunately are not still available, and they are not very cost effective, which is TSH receptor antibodies. Alhamdulillah, now the antibodies have been performed here. When I was a student, this test was not being performed in Pakistan, and this IGF receptor antibody still is not performed, but these antibodies are basically the culprit, which actually inserts itself to the activated fibroblast, which then actually differentiates into either myofibroblast and adipocytes, and all the run of the things and the downstream events leads to this. Either it is the expansion of the retroorbital fat or the hypertrophy of the muscles, which Professor Asad rightly told you, and this is the most common presenting eye disease in our endocrine OPD. You can see the periorbital puffiness along with chemosis and proptosis, which can be commented from the lateral side, and this is exophthalmos and lid retraction. All of this is an ideal circumstances where you should intervene, and we need your help. This is how the CT looks like, and this is the hypertrophied extraocular muscles, and this is the expansion of the retroorbital fat, which actually leads to left side proptosis more than the right. This slide is important because this is relevant to only selenium. We have to know the degrees of there are multiple classification category, but this is the most commonly used, which actually makes us decide whether to do for selenium or not, mild or moderate to severe. The concentration has to be kept to mild, because selenium, which I am going to give you certain evidence for 1 to 2 minutes, it only works in mild. There is no role of selenium in moderate to severe till date. So lid retraction less than 2 millimeter to downstream events, everything should be in this category, whether to decide whether I have to initiate selenium or not. So how does it improve? If you recall the previous slide of pathogenesis, selenium actually, if there is a decreased selenium, it actually fails to inhibit the suppressor T cells, which are by default has to be stimulated, because if the suppressor T cells are stimulated, it actually suppresses the interleukin 2, which is the culprit of downstream events of pro-inflammatory cytokines, and which actually leads to B cell activity and both antibodies. This is IGF-1 and TRAB antibodies, which leads to all the downstream events of fibroblast stimulation and adipocytes and myocytes. So at the last, what are the proof? The clinical evidence chronologically, you go clinical practice, which is the most commonly used reference point, which actually proves that mild and active Graves' ophthalmopathy, control of risk factors, local treatment in only selenium deficient people are actually still to date is known to be a helpful category in selenium initiation, but unfortunately selenium levels are not being done here. Mostly it is a research point of view. And then in 2023, the paper, the Wang F et al. Suggested that some studies have shown that lack of selenium will increase Graves' ophthalmopathy, which leads to the supplementation of selenium and improves the quality of life. And Hall et al. In Internal Medicine Journal proved that TED is strongly associated with thyroid disease, principally Graves' disease. But non-surgical management can extend from anything beyond observation to the orbital radiotherapy, and oral selenium is only approved till date for mild Graves' disease, as I just mentioned. And selenium is the management of mild Graves' ophthalmopathy only, but has no role till date for moderate to severe. And from second last, slide, selenium supplementation is recommended in patients with mild orbitopathy. As just mentioned, the effect on moderate to severe still remains unknown. So, low selenium is linked to autoimmune thyroid disease. As just said, this is still a matter of debate whether selenium should be given to every mild disease patient. Problem is, if the patient is selenium deficient, then yes, it does work. But nobody knows who are selenium deficient because there are rarely any clinical symptoms and we cannot go for blood selenium levels. So selenium supplementation is effective only in mild disease. And thyroid eye disease, euthyroidism is more rapidly achieved in micronutrients added to traditional drugs. This is the take-home message. Last slide. Kindly, selenium has been proposed for the management of thyroid disease, including Graves' disease, Graves' ophthalmopathy, and chronic autoimmune thyroid disease. I have kept this study because of the fact if apart from TRAB antibodies, Graves' disease, selenium actually works in Hashimoto's thyroiditis in decreasing the antibodies, which leads to either cessation or reduction in levothyroxine replacement. So this is still a matter of debate, and it was not in the books when I was doing the fellowship. And the efficacy of selenium in Graves' disease and Graves' ophthalmopathy is based on its antioxidant property, which I just showed you, being oxidative stress being the most pathogenic insult in this condition. And the dose of the selenium is actually 200 micrograms. Some studies are using it 400 microgram. Problem, the only main important problem also is selenium दवाई नहीं है. Selenium is not available everywhere. 2-3 जगहों पर होती है सर कॉल आ जाती है कि selenium available ही नहीं है. ये एक और मसला है पाकिस्तान का. That is the main problem. GNC products है नेचर बाउंड्री की मिल जाती है. They are doing it for online से मिल जाती है, फिर आपको interruption मिल जाती है, apps फिर दोबारा आ जाती है. But actually selenium is a go-to medicine. At least एक नई उम्मीद है. Graves' ophthalmopathy में तो definitely mild से खत्म हो जाए तो आपका रोल ही बनता है. We will just render the patient euthyroid. But आपको मुझसे बेहतर पता है कि despite making the patient euthyroid, thyroid eye disease can worse even in euthyroidism. So we need your help. But selenium still should be replaced as an adjunct only, not the only medicine for mild of Graves' ophthalmopathy. From moderate to severe, it's all you. Thank you. Sir, data में 6 months है along with vitamin D. 6 months 200 mg per day. And then we repeat the TRAB antibodies or TPO antibodies for whatever reason you were giving it.
Can we combine it with doxycycline?
Yes, you can. You can combine it with anything because it's a trace element. So the problem is the most intriguing वो तो मुझे भी जब invite हुआ तो मैंने ज़्यादा डिटेल में सर्च की कि ये सारी studies are actually being done and the substantial significant statistically p value less than 0.05 उनमें ही आई है बेटा जिसमें selenium deficient areas है. Just like जब आपने शुरू में वो undergrad के level पर goiter पढ़ा होगा iodine deficiency है वो आपको idly मिलता है. तो iodine deficiency has been replenished but in fact अब तो overused हो गए. तो selenium deficiency कहाँ होगी? Only time will tell because trace elements बहुत मुश्किल होता है जब तक कि pathology ना हो to have been deficient. At least in our part of world highly unlikely because there are no clinical textbook symptoms which can suggest you इसको selenium deficiency है इसको selenium पा दो. सर selenium multivitamins के अंदर 15 माइक्रोग्राम्स में सिर्फ आती है. मल्टीपल मैंने देखी है जो सिर्फ ओवर द काउंटर वो हैं जो हमारी डिस्पेंस नहीं है, ड्रैब ने अप्रूव नहीं की हुई. सर सनी डी वगैरह जो विटामिन डी है वो भी आपको पता है ऑल्टरनेटिव मेडिसिन के दौर में ही आती है. तो इसके अंदर selenium आपको अभी तक लोकल नहीं मिलती, मिल जाती है लेकिन फिर स्पेसिफिकली बंद हो जाती है. फिर तो जो मल्टीविटामिन्स हैं आप बिल्कुल रेलेवेंट क्वेश्चन है उसमें इसकी डोज बहुत कम है. स्टडीज वाली 200 माइक्रोग्राम्स 15 to 20 माइक्रोग्राम्स होती है. सेम इज ट्रू विद विटामिन B12. हम विटामिन B12 जब पर्निशियस एनीमिया में देते हैं तो खालिस्तान न्यूरोबियन देते हैं. जो मल्टीविटामिन्स होते हैं अपार्ट फ्रॉम B1 B6 B12 प्रिपरेशन उनके अंदर बहुत कम होती है, ओनली 15 to 20 माइक्रोग्राम्स.
Thank you very much. We will take the questions later, please, if we have time.
Now I invite last speaker of this session, Dr. Mara Ashraf. Her topic is biopsy specimen and art of communication.
Assalamu alaikum. My topic of presentation is biopsy specimen and art of communication. I will mainly discuss oculoplastic specimens. It has been reported both internationally and nationally that poor documentation of specimen form leads to difficulty in diagnosing the disease. The basic info record on submission form is as flashed. First of all is specimen marking. For specimen marking, suture is used. It is best to apply sutures when before excising the lesion. For example, in this lesion, we can use lid margin as a landmark, and we can mark medial, lateral, and inferior margin with sutures. If the lesion does not involve any landmark, then mark all margins along the anterior or along with anterior and posterior surface. Care must be taken to avoid crushing of tissues at the lesion margin. After excision, when a sample is taken, the type of test will decide how will you send the sample. If you want frozen section, then sample is sent in gauze piece or in saline. If histopath is required, then sample is sent in formalin. For frozen section, if the lesion is large, then after excising it, take 1 millimeter strip of the margin separately, as frozen section of smaller tissue pieces freeze more evenly and produce better quality sections. The formalin ratio should be at least 10 times the volume of tissue. For conjunctival mapping biopsy, it is recommended to send all samples in separate jars with labeling. Also draw the sample sites on histopath form to avoid any confusion. If a single site conjunctival biopsy is planned, then marking of 2 margins is done. It is preferable to mark the limbal side, and if the tissue is fixed on litmus paper, then mention its orientation in clock hours. Coming on to enucleation, use traction sutures as your specimen labeling sutures. Sutures are applied at the site of recti insertion. Size of the optic nerve should also be mentioned in the submission form. In cases of retinoblastoma, Royal College of Pathologists recommend following points to be mentioned in clinician's form along with pictorial form. On this pictorial form, you can mention the extent of the disease retinoblastoma is involving. I will conclude by saying clinician must be educated and made aware of their primary responsibility to request this service appropriately for the benefit of patient and patient care. Thank you.
Thank you so much, Dr. Amara. I request Professor Tayyib to deliver the concluding remarks.
Thank you very much. This was an interesting variety of presentations, and I think we are already running short of time. I have to make few comments, but there are any questions because some of the speakers have gone already, left. So if there are any questions for the attending participants or attending speakers, then we can give can take 1 or 2 questions. Otherwise, I'm sorry, that speakers should have been around. चलेगा सर, जुम्मे का टाइम हो गया सर, ठीक है सर, थैंक यू वेरी मच. अच्छा नहीं, अभी आप कुछ कहना चाह रहे हैं तो बताइए. नहीं, only thing is we are also using selenium for the last couple of years, but the only problem with selenium is that it is not as accessible. We have to, as I ask some patients to get them from Dubai or from other places. So selenium is good for the first 6 months especially. Mild cases, as the doctor said. So, but it should be used. But also diabetics should be the one point. I don't know whether you mentioned it or not, but diabetics should be more careful when you are giving selenium to them. Anything? Thank you very much.
Thank you, sir. Thank you. Thank you, everyone.